Welcome to our deep dive into mental and behavioral disorders, often abbreviated as M&BD. In this chapter, we'll explore how mental disorders can lead to impairments, affecting daily life and work. We'll also discuss the latest approaches to evaluating these conditions, focusing on how brain function influences behavior. The American Medical Association's Guides, 6th edition, now closely follows the DSM-5, the gold standard for psychiatric diagnosis. This ensures that assessments are consistent and based on the most up-to-date criteria. Throughout this video, we'll break down the principles, diagnostic categories, evaluation methods, and impairment rating systems used for M&BD. Let's begin by understanding why following the DSM-5 is so crucial in this field. DSM-5, or Diagnostic and Statistical Manual of Mental Disorders, 5th edition, is the foundation for diagnosing mental health conditions. The AMA guides emphasize using DSM-5 criteria to ensure that diagnoses are reliable and valid. This means that only well-validated and reliably diagnosed major mental illnesses are considered for impairment ratings. The DSM-5 also removed the Global Assessment of Functioning (GAF) scale, replacing it with more precise tools. By following DSM-5, clinicians can provide consistent, evidence-based evaluations that stand up in both medical and legal settings. Before diving into assessments, it's important for clinicians to be familiar with the AMA Guides, foundational chapters, and glossary. These resources clarify the purpose and methods for evaluating impairment. Notably, having a diagnosis doesn't always mean a person is impaired. Clinicians using this chapter are typically trained in psychiatry or psychology and should have expertise in DSM-5, psychiatric evaluation, and treatment of mental and behavioral disorders. This ensures that assessments are accurate and meaningful, focusing on real-world impacts rather than just symptoms. Definitive diagnosis is the first step in rating impairment due to mental and behavioral disorders. This diagnosis must be based on DSM-5 criteria, which consider a wide range of signs, symptoms, and impairments. Importantly, a mental disorder is defined as a syndrome causing significant disturbance in cognition, emotion regulation, or behavior, reflecting dysfunction in psychological or biological processes. Not every symptom or mild distress qualifies as a disorder. Context and severity matter. The diagnosis also helps predict the likely course and duration of impairment. DSM-5 is continually updated to reflect new research and clinical experience. It introduced specific, observable criteria for diagnoses, making them more reliable across practitioners. Validation of these criteria involves genetic, biological, and clinical evidence. However, no single set of criteria perfectly captures every patient, so clinical utility remains the main standard. The goal is to group individuals in ways that help predict their clinical course and response to treatment, even as our understanding of mental disorders evolves. Not every mental health condition is rated for impairment. The AMA guides focus on major, well-validated disorders like mood disorders, depression, bipolar, anxiety disorders, obsessive-compulsive disorder, trauma-related disorders like PTSD, and psychotic disorders like schizophrenia. Some conditions, such as psychiatric reactions to pain, substance intoxication, primary sleep disorders, dementia, intellectual disability, and psychiatric effects of brain injury, are not rated in this chapter. This ensures that only significant, reliably diagnosed conditions are considered for impairment ratings. And should this chapter be used? If a person has a mental or behavioral disorder without a physical impairment, the outlined methodology applies. If the mental disorder is independently compensable, its impairment rating is combined with any physical impairment. However, if a mental disorder accompanies a physical impairment, psychological issues are usually included in the physical impairment rating, and this chapter is not used. These rules help ensure fair and consistent evaluations in legal and compensation settings. Thorough psychiatric or psychological evaluation includes taking a detailed history, reviewing records, and conducting a mental status examination. This exam covers appearance, mood, speech, thought processes, perceptions, cognition, insight, and judgment. Additional testing, such as psychological, neuropsychological, or laboratory tests, may be used to clarify the diagnosis or assess cognitive function. These steps ensure a comprehensive understanding of the patient's mental health and functional abilities. Mental status examination is a structured assessment of a patient's current psychological functioning. It looks at general appearance, behavior, mood, affect, speech, thought process and content, perceptions, cognition, insight, and judgment. This exam provides a snapshot of the patient's mental state and helps guide further evaluation and treatment. It's a key part of any psychiatric assessment and is often supplemented by standardized tests for greater accuracy. Standardized psychological tests can improve diagnostic accuracy. Tools like the Minnesota Multiphasic Personality Inventory, MMPI, Millen Clinical Multi-Axial Inventory, and Personality Assessment Inventory, PAI help assess personality traits and symptoms. For intellectual assessment, the Wechsler scales are widely used, providing insights into cognitive strengths and weaknesses. Academic achievement tests and neuropsychological batteries further clarify areas of impairment, especially in complex cases. These tools are valuable, but interpretation always requires clinical expertise. Neuropsychological testing is the most comprehensive way to assess mental function. It can take a full day or more and covers intelligence, memory, attention, language, visuospatial skills, sensorimotor ability, and problem-solving. Standard batteries like the Halstead-Rieton or Luria, Nebraska are used, along with flexible approaches tailored to the patient. These tests are especially useful for detecting subtle deficits, such as those seen in early brain injury or severe psychiatric illness. Screening tools like the PHQ-9 or GAD-7 are quick ways to assess symptoms, but they lack validity scales and can be influenced by non-clinical factors. Standardized psychological tests, on the other hand, are normed against large populations and include checks for consistency and response bias. In medical settings, self-report measures must be supplemented by interviews, records, and objective testing to ensure accurate, defensible conclusions. All psychological test results should be reviewed by a qualified examiner. It's important to ensure the tests were properly administered, findings are consistent, and results match the patient's history and records. The examiner should also check for baseline functioning and use appropriate normative data. In medical settings, at least 2 symptom validity tests are standard practice. Ultimately, the patient interview and clinical judgment remain central to the evaluation. Even the best psychological tests have limitations. They are most useful for identifying strengths and weaknesses in cooperative patients, not for detecting malingering or deception. Abnormal test results do not always mean brain damage. They simply reflect performance on specific tasks. Factors like age, education, culture, medication, and motivation can all influence results. That's why a holistic approach, combining tests with interviews and records, is essential. Dependent medical examinations, IME, for mental and behavioral disorders have unique features. Examiners must assess personality structure, defense mechanisms, substance use, legal and military history, and motivation to return to work. They must also consider the possibility of symptom exaggeration or malingering. The examiner's role is to remain neutral and unbiased, focusing on objective evidence and avoiding dual roles that could create conflicts of interest. Physicians conducting IMEs must maintain a neutral, unbiased stance. Unlike treating clinicians who align closely with their patients, IME examiners are tasked with objectively evaluating all available information. This distinction is crucial, especially in legal contexts. Treating clinicians should avoid serving as expert witnesses for their own patients to prevent bias and protect the therapeutic relationship. Comprehensive assessment draws on multiple sources: the patient's own account, family input, medical and non-medical records, and observations of daily functioning. 6 key parameters are considered: self-care, social activities, travel, relationships, concentration, and employability. Consistency across sources is important. Discrepancies may signal unreliable self-reporting or recording errors. The examiner must reconcile any inconsistencies and fill in gaps in the history. Functional impairment in mental and behavioral disorders is measured across 6 domains: self-care, social and recreational activities, travel, interpersonal relationships, concentration and persistence, and employability. These scales help quantify the real-world impact of mental disorders, moving beyond symptoms to assess how a person functions in daily life. This approach ensures that impairment ratings reflect meaningful limitations. Motivation plays a key role in how individuals cope with impairment. Factors like psychiatric illness, medication side effects, legal issues, and social support can all influence motivation. The examiner must carefully assess whether low motivation is due to the illness itself, external factors, or a combination. Understanding motivation helps distinguish between true impairment and other influences on functioning. Lingering, intentionally exaggerating or fabricating symptoms for personal gain exists on a spectrum. Examiners must be alert for signs like vague or inconsistent symptoms, overdramatization, or implausible stories. However, labeling someone as malingering requires strong evidence and should be done cautiously. Alternative terms like symptom exaggeration or reporting inconsistencies are often more appropriate and less polarizing. Condition is considered permanent when it's not expected to change significantly over the next year. In mental and behavioral disorders, this concept can be tricky due to variability in symptoms and course. Some disorders are chronic, with periods of remission and relapse. Evaluations must account for fluctuations in functioning and consider whether the patient has reached a stable plateau. Mental disorders vary widely in their course and severity. Some are chronic, while others may resolve with treatment or time. The degree of impairment can differ greatly even among people with the same diagnosis. Evaluators must consider the natural course of the disorder, response to treatment, and the individual's resilience and coping strategies when determining impairment. Evaluating impairment includes reviewing the patient's response to treatment. Has the treatment been appropriate and followed accepted guidelines? Has it improved function? Medication adherence, side effects, and comorbid conditions must all be considered. Residual symptoms after optimal treatment represent the true degree of impairment. This thorough review ensures that ratings reflect the patient's best possible outcome. Workplace functioning is a key aspect of impairment. Some individuals may have significant impairments outside of work but still perform well on the job, while others may be unable to work due to even mild symptoms. It's rare for impairment to affect only work. Employers' willingness to modify work conditions can play a major role in successful return to work. Some individuals maintain stability only in structured settings like hospitals or group homes. Their ability to function outside these environments may be limited. Evaluators must consider whether repeated deterioration occurs when the patient tries to return to work or live independently. This helps determine the true level of impairment and the need for ongoing support. AMA guides use two main scales to rate impairment from mental and behavioral disorders: the Brief Psychiatric Rating Scale, BPRS, and the Psychiatric Impairment Rating Scale, PIRS. The BPRS measures symptom severity, while the PIRS focuses on role function across 6 domains. Using both scales provides a comprehensive view of the patient's condition and supports a well-rounded impairment rating. BPRS is a widely researched tool that measures major psychotic and non-psychotic symptoms. It consists of 24 symptom constructs, each rated on a 7-point scale from not present to extremely severe. The total score determines the impairment percentage. This scale is reliable and helps quantify the severity of psychiatric symptoms in both inpatients and outpatients. PIRS evaluates behavioral consequences of psychiatric disorders across 6 domains: self-care, social activities, travel, relationships, concentration, and employability. Each domain is graded from 1 to 5, and the sum of the middle 2 scores determines the impairment percentage. This approach balances outliers and provides a fair assessment of overall functional impact. Rating psychiatric impairment: only clinical conditions that meet rating criteria are considered. Even with multiple diagnoses, only one impairment rating is given. Pre-existing personality vulnerabilities and borderline intellectual function are not rated. The evaluator must distinguish between impairments due to the current illness and those from chronic pre-existing conditions. Limitations due to physical impairments are also excluded from M&BD ratings. Impairment rating process involves 3 steps. First, calculate the BPIS impairment score by summing the 24 symptom ratings. Second, determine the PIIS score by grading each of the 6 domains and summing the middle 2 scores. Third, average the BPRS and PIIS scores to get the final M&BD impairment rating. This method ensures a balanced and comprehensive assessment. Let's look at a real-world example. A 55-year-old real estate developer experienced severe depression with symptoms like hopelessness, fatigue, and loss of interest. After a year of treatment, he improved but still had trouble concentrating and enjoying activities. His BPRS score was 0%, and his PIIS score was 10%, resulting in an average impairment rating of 5%. This case highlights how ratings reflect both symptom severity and functional impact. 32-year-old woman with chronic schizophrenia had stabilized positive symptoms but continued to struggle with motivation and social functioning. Her BPIS score was 10% and her PIIS score was 20%, averaging to 15% impairment rating. This example shows how even when symptoms are controlled, functional limitations can persist and must be considered in the rating. 23-year-old veteran developed post-traumatic stress disorder after combat. He experienced intrusive memories, nightmares, and emotional numbness, affecting his work and relationships. After treatment, some symptoms improved, but functional issues remained. His BPIS score was 15%, PIIS 10%, for a final rating of 13%. This case illustrates how trauma can have lasting, measurable impacts. 49-year-old welder developed an adjustment disorder with anxiety and depression after a work injury. Despite some ongoing symptoms, he returned to work and managed daily activities. His BPRS and PIIS scores were both 5%, resulting in a 5% impairment rating. This case demonstrates that not all psychological responses to injury result in significant impairment. 40-year-old woman with a history of trauma, substance use, and multiple psychosocial stressors presented with adjustment disorder and somatic symptom disorder. Despite subjective complaints, objective findings were minimal. Her BPRS and PIIS scores were 10% each, for a final rating of 13%. This case highlights the importance of objective evidence and careful assessment in complex situations. Some conditions, such as antisocial personality disorder and substance use disorders, are not rated in this chapter. For example, a 32-year-old man with a history of substance abuse and antisocial behavior was not given an impairment rating, as these conditions are excluded unless altered by a current injury. This ensures ratings are reserved for conditions with clear, rateable impairment. 35-year-old man with severe schizophrenia experienced delusions, hallucinations, and significant functional decline. He was unable to live independently or maintain employment. His BPRS and PIIS scores were both 50%, resulting in a maximum impairment rating. This case underscores the profound impact severe mental illness can have on every aspect of life. BPRS includes 24 symptom constructs, each with specific definitions and rating anchors. Symptoms like somatic concern, anxiety, depression, suicidality, guilt, hostility, and others are rated based on self-report and observed behavior. Each symptom is scored from 1, not present, to 7, extremely severe, with clear guidelines for each level. This structured approach ensures consistency and reliability in scoring. Each BPRS symptom has sample questions to guide the interview. For example, to assess somatic concern, the examiner might ask about worries regarding physical health or changes in appearance. For anxiety, questions focus on worry, nervousness, and physical symptoms. These targeted questions help elicit accurate information and ensure that ratings reflect the patient's true experience. BPRS items are rated based on observed behavior, such as conceptual disorganization, blunted affect, emotional withdrawal, motor retardation, tension, uncooperativeness, excitement, distractibility, motor hyperactivity, and mannerisms. The examiner watches for signs like disorganized speech, flat emotional expression, or unusual movements. These observations provide objective data to supplement self-report. PIRS assesses 6 domains: self-care, social activities, travel, relationships, concentration, and employability. Each domain is graded from 1 no deficit to 5 totally impaired, with detailed descriptions for each level. This approach captures the impact of mental disorders on daily life, ensuring that ratings reflect real-world limitations, not just symptoms. Calculate the PIRS score. Each of the 6 domains is graded from 1 to 5. The scores are arranged from lowest to highest, and the middle 2 scores are summed. This sum is then converted to an impairment percentage using a standard table. This method reduces the impact of outliers and provides a balanced assessment of overall impairment. Final impairment rating is the average of the BPRS and PIRS scores. This combined approach ensures that both symptom severity and functional limitations are considered. It provides a comprehensive, defensible rating that reflects the patient's overall level of impairment due to mental and behavioral disorders. Summary: evaluating impairment due to mental and behavioral disorders requires a structured, evidence-based approach. The DSM-5 provides reliable diagnostic criteria, while the BPRS and PIIS offer standardized ways to rate symptom severity and functional impact. Comprehensive assessments draw on multiple sources and consider motivation, malingering, and response to treatment. This ensures that impairment ratings are fair, accurate, and meaningful. Thank you for joining us on this comprehensive journey through the assessment and rating of mental and behavioral disorders. By understanding the principles, tools, and real-world examples, we can better appreciate the complexities involved in evaluating impairment. This knowledge supports fair outcomes for patients, clinicians, and legal systems alike. Stay tuned for more in-depth explorations of medical assessment topics.